Hello. So thank you very much to all of you for this excellent presentation. We have some time for questions, so please send your question by the chat to discuss these three presentations. First, I would like to thank all of you three for these very interesting and very exhaustive presentations. I will start with Dr. Rubin. Do you perform a genotypic test for integrase inhibitors for naive patients in Canada systematically, and maybe especially for dolutegravir plus 3TC when you are planning to initiate this treatment? Do you wait for the results of the genotypic test before the initiation?
Yes, we do genotypic testing on everybody as based on routine initial visits. Most of my colleagues will wait for the genotype to come back before starting. It's not because we have any significant integrase resistance in our population, but it's very old school. You like to know what that virus looks like before you put people on medication. There certainly is a move for rapid starts. But I must admit, I'm not a real big fan of rapid starts. I don't really see the need for it unless, of course, somebody has, a very, very low CD4 count, less than 200 per se, or they have an opportunistic infection. And in many of those cases, we'll put people on a boosted protease-based regimen just to make sure we have a very high barrier, since we don't really know what that person has got in their reservoir. And when the genotype comes back, then we may switch them to integrase-based regimen at that point.
Okay, thank you. This is the same in France. We perform systematically genotypic resistant testing before initiation, and but sometimes clinicians do not wait for the result. They start with a high genetic barrier and then adapt the treatment after.
Yes, and we have such low integrase resistance in our population that most of my colleagues would probably just put somebody on integrase-based regimen if they really felt the need. But like I said, we're not seeing very many patients who really need urgent rapid starts at this particular point.
Okay, thank you. There is a question about from the audience about suppressed patients. What do you think of dual treatment in patients that are already suppressed?
Are you talking about like a Dovato-based regimen in people who are suppressed?
Yeah.
Yes. It's interesting because we are seeing probably a lot more patients coming in requesting the switch to Dovato than physicians are initiating it. But yes, there's no real reason why anyone could not take Dovato from going from other suppressed regimen, unless, of course, you were concerned about a 184 or some other mutation existing. But some of the data would suggest people with 184 actually do better on Dovato. There's something about the presence of a 184 that hypersensitizes to dolutegravir or prevents dolutegravir from going down its main resistance pathway. But in most of our patients who have genotypes at baseline with no significant mutations, we treat Dovato as we would treat any other simplification regimen.
Okay, thank you. So maybe I have a question for Dr. Kozal. Thank you very much for the very interesting data about the resistance in experienced patients. And for example, do you perform a DNA proviral genotypic test in your practice, or to decide about the treatment for these patients?
Yes, many of the times that when we have complicated patients that we're worrying about that we're not seeing all the prior resistance mutations, I will recommend doing proviral DNA genotyping. Now, I have a unique practice because we are a heavily treatment experienced area and we get referred patients from all over, for our trials and things. And so most trials also now are using proviral DNA genotyping if it's something that they're going to want to do. If you're doing a switch study or the like, and that sort of touches on what Gary's point was. People are considering doing proviral DNA genotyping in people that are switched, that are suppressed, that are going to be switched to dual therapy with dolutegravir plus 3-TC. And so the guidelines, at least in the United States, recommend they give it a C3, means it's only based on expert opinion. That you can use it, and so you can decide to use it or not use it. But the big caveat about proviral DNA genotyping is it does not sample all the archived virus. Usually when you do an assay like this, you only take about 4 milliliters of blood, and within that you might only have 50% of the peripheral blood mononuclear cells or CD4 cells. So really you're sampling only about 2 million cells. And in people that are suppressed, that means there might be only 4 to 40 archived proviral DNA genomes in that amount. So you really are just getting a very small sample. So if you detect resistance mutations, that gives you some confidence that you're detecting them. If you're not, then you can't say they aren't there. And that's where the historical genotypes are really just as important as a proviral DNA genotype. So I know I gave you more than you wanted there, Jenny, but yes, we do use it.
Yeah, in France also, and in the same way, if there is a mutation in the genotypic resistant DNA, we are taking account it, and if there is no mutation, so we don't know.
Right.
And especially because so yeah, but sometimes it's very difficult to get the past historical RNA genotype for patients that have a very long history of antiviral treatment. Sometimes they change of centers, so it's very, very difficult to have the historical past genotype. So DNA could be useful in these cases. I have a question about fostemsavir, because the results are very very interesting, especially I think in the non-randomized cohort with substantial patients with a good virological response. What do you think about potential additive activity between fostemsavir and ibalizumab?
So the data for that is it's very, very limited. There was 15 patients that had ipilimumab plus fostemsavir. So you're talking about 15 to 18 patients. That's how small the number is. At week 48, patients that received ipilimumab and fostemsavir in the non-randomized cohort looked just like the randomized cohort. Around 58, I think it was 55 to 58% of them were non-detectable. So very robust. However, by week 96, when that data comes out in a couple of weeks, you'll see that it fell at week 96 down to about 35%, back down to where the non-randomized cohort are. And it probably is that you only were really treating those people with dual therapy. And it's really hard. Some patients have a difficult time staying on IV infusions for 2 years. And so there's it's a large dropout too. So we really don't know. And that was by intent to treat. So you can't really describe those two. But they have different mechanisms of action. One's a post-attachment inhibitor, and one's a pre-attachment. One binds to the virus. The fostemsavir actually binds to the virus before the virus actually attaches. So they can be used together if a patient is willing to do IV infusion.
Okay, thank you. I I think we do not have some question about the audience, but um, maybe Dr. Flexner, um, thank you for showing the data about the flare and the Atlas study. Giving the risk of emergence of resistance mutation in case of virological failure with rilpivirine plus cabotegravir. What do you recommend to do in case of missing injection or even stopping treatment for patients who are under rilpivirine plus cabotegravir?
Thank you for that question, Marceline. The current recommendation for patients who miss an injection or are late for their injection is to start taking replacement oral daily combination therapy. And there have been some very good pharmacokinetic modeling exercises that have been presented recently to show the benefit of either using combination oral cabotegravir and rilpivirine as the replacement to sustain concentrations of those drugs. But I think there is also the possibility of switching to the combination oral regimen the patient was on prior to the switch to injection, because we know that regimen worked and we know that that regimen was tolerated. But I do think it's important for people switched to injectable regimens to make sure they have a backup supply of oral medication in case, for whatever reason, they can't make their next injection appointment. And this is something we're going to have to incorporate into our practice once these regimens become available and are more widely used.
Okay, so you would recommend to take the oral treatment until the further injection?
Yes, I would continue the oral treatment every day the patient has missed an injection until the next injection. And I think that there are good data now to suggest that that will prevent the drug concentrations from falling into a range where resistance could develop.
Okay, thank you.
Can I say, Charles?
Yes, of course.
I agree with you, and I find that really fascinating because that's what we've been talking to our patients about who want to start Cabenuva. But it's interesting that we're going to the injection route to improve compliance and adherence, and we're already talking about people who can't maintain compliance on their monthly injections. And then we ask ourselves, well, maybe this person shouldn't be on the injection. Maybe they should go back or stay on the oral. So it's an interesting problem.
Thanks for chiming in, Gary, because you are on the front lines of using injectable regimens, because you're in the country that has been the first to approve injectable cabotegravir and rilpivirine. This is something we have all talked about. If you have a patient who you think is not going to be able to reliably show up to receive their injections, maybe that's not a great patient for a monthly injectable regimen. And you know, I wouldn't say that patient could never get an injectable or an implantable drug, because I think as we learn more about these drugs and as development continues, the dosing interval will get longer and longer and longer. And so maybe someone who can't come in every month could come in every 6 months or a year. And so I think as we get more of these agents and more options for our patients, I think we'll be able to customize this a bit more. But you're right, it is going to raise some questions for people who have a history of not showing up for their clinic appointments.
And Dr. Flexner, there are some data showing that maybe in a woman there is a longer tail of rilpivirine and cabotegravir. Could you comment on that?
Yes, there are data that were recently presented showing that the pharmacokinetic profile of cabotegravir is different in women than it is in men. Specifically, on average, women have a slower release of the drug from its reservoir, but a longer tail. So early after initiating cabotegravir, the average concentrations are lower in women, but at the end of 48 weeks, the concentrations are actually higher. And that's consistent with this concept of women having a slower release, but release over a longer period of time. They did look at the antiviral efficacy and resistance in the women versus men in Atlas and Flare, and fortunately, there's no difference. So the outcomes were just as good in women and as in men, although keep in mind, there were very few treatment failures in those studies. So I think it would be hard to say with 6 or 8 treatment failures that men are doing better or worse than men. And so I do think this is something we need to keep an eye on, but it's an interesting observation about the pharmacokinetic profiles of these injectable antiretrovirals that are given intramuscularly. I think this is something that's going to be specific to intramuscular injection, and more importantly, the difference between men and women in pharmacokinetics was not seen with injectable rilpivirine. So this is not a generic effect of injectables in men versus women. It was formulation specific, and it was only seen with the cabotegravir formulation, which is interesting.
Okay, yeah, very interesting. And so would you recommend to perform plasma measurement of rilpivirine and cabotegravir for patients receiving this formulation?
That is an important question that has not yet been answered. And I do think we need to keep in mind that the treatment failures in Atlas and Flare were in individuals who had low drug concentrations. And so I think we need to think this through. How would we respond to low drug concentrations in an individual patient? Would we simply monitor them, or would we actually increase the dose of the cabotegravir and or the rilpivirine? We don't have an answer to that yet. It's also important to point out that although the individuals who failed therapy had low drug concentrations, there were plenty of individuals with low drug concentrations who did not fail therapy. And so if we did therapeutic drug monitoring and altered the dose for those with low drug concentrations, we would probably be doing that unnecessarily in a lot of patients who receive these formulations. So I think we have a lot to learn about that still. It's a great question.
But viral load is the most important thing. Okay. We had a question for Dr. Kozal. Can you say something about the intention to treat results for fostemsavir? Maybe you could comment on that.
So I think
in the last minutes we have. Sorry.
Sure. Yeah, I think maybe they're touching on, which was very unique about fostemsavir. First, it was, I mentioned that there was 10 trials for highly treatment experienced patients over the last 10 years, at phase 3 randomized trials. This is one where the FDA snapshot analysis out to 2 years. This is very unique in that fostemsavir actually had an increase in response rates in the intent to treat between week 48 and week 96. Patients continued to virologically suppress. And it wasn't because their OBT was optimized backbone therapy was changed. And so it really is a very unique finding where patients at week 48, 53% were non-detectable by intent to treat, and it went up to 60% at week 96. And so it's a very unique finding with fostemsavir. It's under investigation. They don't know. People are wondering if it's the unique mechanism of action of fostemsavir, the way that it binds to GP120 to actually freezes it in a confirmation that maybe the immune system can recognize HIV better. But it's a very unique finding where the other phase 3 trials that licensed other drugs didn't really see a rise between week 48 and week 96. They actually saw a decline in intent to treat responses, but fostemsavir trial there was an increase from 53% to 60%. And that's going to be published hopefully in the next couple of weeks in a major medical journal. So for those of you that didn't see it being presented in Mexico City, but I'll stop there, and because I meet the professors and people can ask me more questions about that later if they want.
Okay, thank you very much. Thank you to everybody for your presentation and your and the excellent discussion. So I think I will close this session. Thank you very much. So if I can have the slides, please. Okay, so thank you very much for this first session of this HIV forum. It was a pleasure to chair this session with my excellent colleagues. And there will be another session at 2:30 with dedicated to reduce drug regimen. This session will start in 10 minutes, and it will be chaired by Dr. Jonathan Shapiro. So you can have now a short break, a short coffee break, and please be connected at 2:30 for the next session. And thank you very much. It was a pity to do not have the possibility to have this meeting in Paris. As you know, the situation is very critical regarding the COVID-19, but I hope that we can organize a new HIV forum in the coming months, maybe in Paris. Thank you very much, and have a good day and an excellent meeting.